Well, welcome everybody to this evening's lecture. Vet Education is proud to present a lecture on analgesia and anaesthesia of the patient with liver disease. This lecture is brought to you by the Vet Education course that we have starting on April 20th called Hepatobiliary Emergencies in Small Animal Practice, so it ties in pretty nicely. It's a 4-week course, starts on April 20th, runs for 4 weeks. We have each Monday evening, if you're in Asia, Australia, New Zealand, earlier times if you're elsewhere in the world, we have weekly tutorials, much like this, in which we are going to cover some of the course material, some cases, and invite discussion and questions. So we have live Q&A sessions as well. In that course. During the course, we'll be covering the physiology and pathophysiology of liver disease. We'll cover acute liver failure, which is an extremely serious and important disease. We'll talk about cholangiohepatitis. We'll talk about biliary tract disease. And finally, we'll talk about diseases like hepatic lipidosis, hepatic encephalopathy, portosystemic shunts, and so on, all in the setting of emergency patients. So we're going to be dealing with the most emergent presentations of patients with hepatobiliary diseases. I'm going to answer any questions you may have about that course as we go through the lecture tonight. But let's kick off with a case. Now, we have a patient. This was a real patient. This, unfortunately, is not the picture of the real patient, but he was a 3-year-old male-neutered beagle who ate a cycad pot plant. And cycad or sago palm toxicity is pretty serious in dogs, and this dog managed to dismantle an entire cycad out of the pot plant. He presented to us a few hours after eating with vomiting and diarrhea on presentation. His owners had been out, they came home, the pot plant was destroyed, and the dog was vomiting, excessive salivation, large amounts of hemorrhagic diarrhea on presentation. He presented to us obtunded. He still had gag and swallow responses, but he was severely dehydrated. He was in shock on presentation, and he was mentally dull and depressed as well. So, before we move on, I just want to talk very, very briefly about cycad toxicity because it has relevance to what we're going to be talking about when we're talking about a choice of anesthetic drugs. And this is an approach that I really like to use when we're talking about choosing an anesthetic, not only for liver disease, but for other diseases as well, as to think about what's caused the problem in the first place, because that can have some quite serious implications in terms of how we go about selecting drugs. If we are going to select pharmacological interventions for our patients, we kind of need to know a little bit about the underlying disease. So cycad toxins are broadly intestinal irritants. Some of the toxins are hepatotoxic, generally interfere with cell protein synthesis, so the cells slowly die. And in fact, a lot of cases of cycad toxicity, the degree of elevation of your liver enzymes is actually may not be as significant as it might be, for example, with mushroom toxicity, for example, or an idiosyncratic reaction to, say, a non-steroidal anti-inflammatory drug or something of that nature. So frequently, yes, the liver enzymes, ALT, AST, and even alkaline phosphatase are elevated, but they may not necessarily be dramatically as elevated as perhaps patients with other causes of acute liver necrosis. And please let me know if that's been your experience, if you've seen some of these cases before. But some of the toxins that are found in these cycad palms are also neurotoxic, so they can cause central nervous system dysfunction, either depression, stupor, and coma, and maybe even seizures in some patients. Congestions, these toxins can be carcinogenic as well, and they may in fact be teratogenic if they are consumed within the gestation period of a dam, for example. Broadly categorized, there are 2 big groups of toxins, the Methyl-azoxy-methanol glycosides, or MAM for short. These are found throughout the plant, okay, in the leaves, in the seeds, and in the roots as well. A couple of examples that you may read of are cycasin and macrozamin. These MAM toxins inhibit RNA polymerase, and this is one of the reasons or one of the methods by which they inhibit protein synthesis. If you inhibit RNA polymerase, your cells cannot produce proteins as they would normally do. They become hydrolyzed by plant glycosides, glycosidases and gut enzymes to form a separate group of compounds called aglycones. And the aglycones alkylate your DNA and cause cell necrosis, carcinogenesis, mutagenesis, and neurotoxicity as well. So this MAM toxins not only inhibit protein synthesis, which is what we typically associate with them when they're causing increases in liver enzymes, but they can also cause cell necrosis elsewhere in the patient as well. For example, the gastrointestinal tract, and importantly, they can cause neurotoxicity as well. The second large group of toxins from cycads is the Beta-N-methylamino L-alanine, or BMAA toxins, and these are typically neurotoxic amino acids. They're found in the highest concentrations in the seeds, and these are the compounds that cause neurological symptoms with prolonged exposure. And this has been found in people in the Pacific Islands where a lot of these seeds are consumed over a person's lifetime, and so neurological disorders can be a prominent feature of prolonged and sustained exposure to these toxins. So the early symptoms of toxicity are typically gastrointestinal irritation. So we get acute vomiting, diarrhea, nausea, excessive salivation in these patients. Over the next 12 to 36 hours, patients become anorectic, so they're not wanting to eat anything, and they can suffer from acute neurological toxicity if the amount of toxin they ingest is significant enough. So those MAM toxins, toxin derivatives that we associate with neurological problems in the acute stage can cause tremors, ataxia, depression, and seizures, as we mentioned before. Over perhaps between 1 and 3 days, these patients can then start to develop symptoms of liver disorder, and the symptoms usually begin with an increase in bilirubin, and we'll see changes in serum biochemistry of increases in ALT and AST, maybe alkaline phosphatase as well, and clinically these patients may begin to develop jaundice along with the anorexia and perhaps persistent mild gastrointestinal symptoms such as vomiting and maybe diarrhea as well. Over a period of a few days, these patients can then develop some progressive liver liver dysfunction that can result in the presence of ascites. These patients can develop bleeding disorders, and I'll talk about that a little bit more later on. And in the, I suppose, the not the induction phase of their illness, but perhaps the maintenance and recovery phases, these patients can become quite polydipsic as well. Clinical pathology is classically characterized by hyperbilirubinemia. ALT and AST will be elevated. We'll see an elevation in alkaline phosphatase. As the disease progresses over perhaps 1 to 2 days, the albumin concentrations can begin to fall. The hypoglycemia can also begin to become a feature of the disease as well. So it's really important, just as a side note, if you're seeing persistent central nervous system dullness in these patients, that to be sure that you are monitoring these patients' glucose concentrations. Clotting times can become prolonged because the liver is the primary source for most clotting factor production in the body. And we can also have patients that develop disseminated intravascular coagulopathy if their liver disease is really severe. And, liver disease is very severe, and that can be associated with significant inflammation, and that can trigger off DIC. And we can also sometimes end up with patients that develop pancreatitis as a result of cycad toxicity also. As far as treatment is concerned, I won't spend a whole lot of time on this because this is an anesthesia talk, but we need to decontaminate these patients' gastrointestinal tract. Activated charcoal, usually given every 8 hours or so for about 3 to 5 days in order to bind this toxin up. It is circulated through enterohepatic recirculation, so repeated doses of activated charcoal are thought to be beneficial in terms of binding binding MAM in particular that is being repeatedly excreted through the biliary tract. Cholestyramine is also a binding agent. It will actually bind MAM toxins within the gastrointestinal tract and prevent enterohepatic recirculation. Then the rest of the treatment we have is really supportive in terms of fluid therapy, gastrointestinal and nutrition support, so antiemetics and so on, renal support, so making sure that we have adequate renal perfusion and hydration in our patients, monitor cardiac rhythm and monitor our patients for electrolyte disorders and so on. And then we look at supporting liver function through the use of drugs like acetylcysteine, vitamin C, ethanol, perhaps because the metabolism of the cycad toxins can involve alcohol dehydrogenase enzyme. So if we saturate our patient's body with ethanol, there may be an inhibition of the ability of the patient to be able to metabolize cycads to active toxic compounds because we've inhibited this alcohol dehydrogenase. Ursodeoxycholic acid has been recommended in some references but not in others. There's a little bit of a question mark as to whether or not it may be helpful. I guess if you do not have biliary tract obstruction and you have signs of significant cholestasis going on, then ursodeoxycholic acid may be of some benefit for patients. But symptoms of overt liver failure are typically associated with low albumin, complete loss of the ability to stimulate or to produce normal clotting factors, for example, and the development of severe ascites due to fibrosis in the liver typically occurs 10 days to 3 months afterwards. So this is a disease that can rear its ugly head for several weeks later after ingestion. The prognosis is actually not all that good. 32 to 50% survival in the published literature. That's certainly my impression in that sort of ballpark, when depending on how severely unwell these patients are and how much cycad they've eaten when they present. Again, the dose makes the poison. We've talked about in our toxicology symposium earlier this year. The dose makes the poison. So those patients that have had a large ingestion of cycads or sagopalms with delay in decontamination typically are going to go on to exhibit more severe signs of toxicity, and that may be associated with worse prognosis. The ALT in non-survivors is higher than that in survivors. Bilirubin, non-survivors actually have higher bilirubin concentration on presentation than survivors, which is interesting. Non-survivors have low point or nadir of their serum albumin concentration. Non-survivors are more likely to have worse coagulopathy, and administration of activated charcoal on presentation was correlated with survival. So these are all key points in terms of your prognosis. But let's now have a look at our patient again. He had decontamination of his gastrointestinal tract, activated charcoal. He was placed on SAMI as a liver protectant drug. He had gastrointestinal support medications. I think he had ranitidine or maybe omeprazole, and he was on meropenem as well as metoclopramide as antiemetics, and he was placed on intravenous fluid therapy to help him maintain hydration because he was so dehydrated on presentation. On day 3, we'll skip to day 3, he was tolerating some nasogastric feeding, but he didn't really have adequate calorie intake through nasogastric feeding. And at that particular point in time, his ALT was 1,200 units per litre. That's about 6 times higher than normal. AST not markedly elevated. Alkaline phosphatase, again, probably about 10 times higher than normal. Urea, about 1.5 times normal. Creatinine, or nearly 2 times normal. Creatinine, about 3 times normal. Bilirubin, about 7 times normal, and he had hypoalbuminemia, a prolonged clotting time of 198 seconds, and he had a decrease in his platelet count. And we thought that his platelet count was possibly low due to the possibility of him having perhaps early signs of disseminated intravascular coagulopathy secondary to the amount of liver damage that he had. All right, on day 3, it was decided that an esophagostomy tube placement would be beneficial because this guy was in for the long haul. His owners were very, very committed, and so the decision was made to try to prepare him to have that tube placed so that we could look after his caloric intake adequately and feed him a diet that was appropriate for his condition. So that's really our patient, and this is the point at which we're going to say, okay, what are we going to give our patient in terms of an anesthetic drug or combination of drugs to help optimize the chances that this little guy is going to survive his anesthetic, that he's not going to die because of increased bioavailability of drugs because his albumin concentration is low, or that he's not going to bleed excessively because we're going to make a hole in him in terms of in his esophagus to place the feeding tube, that we're not going to give him the wrong drugs that are going to stick around for a long time because his liver may have decreased ability to metabolize the drugs that we're going to give him. So let's move on and have a look at anesthetic consideration. And we've kind of mentioned some of these things. The biotransformation of and metabolism of anesthetic drugs is typically reduced. So what that means for us in terms of anesthesia is that whatever we give our patient typically is going to last a little bit longer if it is biotransformed or excreted in the liver. And I guess the spoiler alert is most of our anesthetic drugs that we give to our patients, particularly our injectable drugs, are metabolized in the liver, and so whatever we give our patient is going to stick around for a little bit longer. Now, some drugs are safer than others to give, but they all are going to last a little bit longer in our liver patient than they otherwise would. We need, as we mentioned before, to consider glucose because the liver has a key role in glucose metabolism. It is the chief organ in the body that undergoes glycogenolysis and gluconeogenesis. So it stores excess glucose and it produces glucose when serum glucose levels fall. If we have a patient that has liver damage, then that function of glucose regulation and the ability to respond to varying serum concentrations of glucose decreases. The liver, as we've mentioned before as well, is the key organ that produces most of our coagulation factors. And so if we have if we have severe liver disease, we can have a patient that develops a severe coagulopathy. They may not be able to respond to bleeding simply because the clotting factors are not there. We have evidence in our patient already that this patient has a prolonged activated clotting time. Yes, it's a crude test, but if we were to do APTT and PT analysis, we would find that those times are prolonged as well. So if you've got a patient with prolonged coagulation times, we need to look after that. Albumin production typically in patients with inflammatory disease goes down because it is a negative reactive protein in inflammatory disease. Plus, the liver is the sole organ that manufactures albumin in the body, and so if we have poor liver function, we get decreased albumin production as well. These patients oftentimes have disorders of fluid balance. They may have central nervous system depression because they're dehydrated and hypovolemic. They may be acidotic, but they also might have hepatic encephalopathy as well. And the other thing I want to mention is carbon dioxide. Both high carbon dioxide concentrations and low carbon dioxide concentrations will cause vasoconstriction and reduced hepatic blood flow. And that has implications for our anesthetic because we need to make sure that our patient is not hyperventilating or hypoventilating when they are under an anesthetic. We want their end-tidal CO2 to be within the normal range in order to optimize vascular tone within the liver. They can also have other problems as well, such as vomiting and regurgitation. So when we're anesthetizing a patient, the use of antiemetics, and I see somebody said, what about antiemetics like meropitant citrate, metoclopramide, maybe ondansetron or dolasetron, are really helpful in terms of suppressing vomiting as well, but we also need to look at postural support for our patients that are undergoing anesthesia. The postural support that's possibly the most helpful would be to put a towel or a sandbag or something under the scapula of your patient so that any fluid that is regurgitated during surgery has to run uphill to reach the shoulder blade where you've just put your towel or sandbag, and then it runs downhill out the mouth of the patient. So if regurgitation is significant, we get a gravity-dependent flow of regurgitated material out the mouth. And I would recommend this for any patient that is at high risk of perhaps aspiration. Even like patients with GDV, for example, when you're untwisting their stomach, they oftentimes have got quite a high chance of regurgitation. This is a really good safeguard sort of maneuver to have. And analgesia, yes, the liver is inflamed. When it's inflamed, do animals always show abdominal pain to us in terms of clinical signs? Not always, but an inflamed organ usually is a little bit swollen. It's reasonable to expect that there will be some discomfort. So we need to think about analgesia for our patients for their underlying disease. We also need to think about what we're going to do to our patient, be it a liver biopsy or a placement of an esophagostomy feeding tube as we're going to do for our patient as well. Let's look now at anaesthetic considerations. We've got reduced oxidation and glucuronidation, which generally leads to an increased serum half-life. Here's the list of anaesthetic drugs in our patient that is affected by decreased liver metabolism. We have barbiturates, benzodiazepines, any of the opioids that we use, most of the opioids. I won't say any of the opioids. Phenothiazines, non-steroidal anti-inflammatory drugs, ketamine, alpha-2 agonist, alfaxolone, and lidocaine as well. In terms of pre-medication, let's get on to the drugs that we're going to talk about. Generally speaking, I've split these up into drugs to avoid, drugs that you kind of can use, that you should probably use with a bit of caution, and then drugs that we probably prefer to use in our patients with liver disease. Drugs to avoid, acepromazine. Here's why. It's metabolized in the liver, like a lot of these drugs. There is no antidote for it, so once you give it, you are stuck with it, and it's going to be stuck with it for a long time because it's a long-acting drug. We have also reduced platelet aggregation if it is used concurrently with atropine, which is an interesting fact. Alpha-2 agonists, things like xylazine, dexmedetomidine, and medetomidine are also best avoided simply because they cause quite significant cardiovascular alteration in our patients. There is some thought that they may be hepatoprotective. In one study that was experimental study, they found that liver enzymes at a period of time after, I think it was medetomidine administration to patients with liver disease actually went down. The problem, and the reason I have a question mark there, is that the samples that were taken in this particular study were not standardized in the post-operative period. So some were taken immediately after surgery and some were taken 2 or 3 days later. So I'm not sure that we could for certain say that these drugs are liver protective. It may well have been the underlying disease that in fact led to that may have been resolving that led to the decrease in liver enzymes. Interestingly, however, despite the quite significant alterations in vascular tone after giving alpha-2 agonist, the intense peripheral vasoconstriction and the marked bradycardia that occurs secondary to that, then following that we get significant vasodilatation. Despite all of those things that happen with alpha-2 agonist, liver flow is remarkably well preserved. These drugs are reversible and they are metabolized in the liver, so we expect them to last a lot longer. In most critically unwell patients, the significant cardiovascular alteration in terms of bradycardia, decreased cardiac output, and the change in respiratory rate and function are the main reasons we avoid these drugs in a critically unwell patient with liver disease. The use with caution drugs are benzodiazepines. They have fairly minimal cardiovascular effects, so their cardiovascular safety is actually pretty good. They're potentially reversible with flumazenil. However, they do undergo quite extensive liver metabolism, so we expect their half-life to be much, much longer than it would be in a normal patient. So the dose that will be required to achieve therapeutic concentrations is going to be a little bit lower than it would normally be. So normally we decrease the dose of benzodiazepines that we use. The other thing is that you can get quite profound sedation in patients with hepatic encephalopathy. And the reason that this is postulated is that the number of GABA receptors, and remember that benzodiazepine is a GABA agonist type of drug or GABAergic drug, the number of GABA receptors in a patient's brain that has hepatic encephalopathy is thought to increase, and there are dramatically increased numbers of GABAergic compounds in the circulating and amongst the brain as well in patients with hepatic encephalopathy. If we then add a benzodiazepine to it, we are essentially giving them a higher dose of drugs that they already have. They have more receptors to receive those drugs, and so the pharmacological effects are much, much more profound. So if you are going to use benzodiazepines, and I know of many anesthesiologists who do use benzodiazepines in patients with hepatic encephalopathy that are seizuring, for example, and certainly I have done so as an emergency clinician, we just decrease the dose quite significantly, maybe to even a quarter to a half of the normal dose of benzodiazepine that we may be using. What are we left with? We've got the drugs we don't really want, ace-promazine and alpha-2s. The use with caution drugs, they're the drugs like benzodiazepines we use if we have to, but we just got to use them with caution. Then there are drugs that we might want to use. Opioids are the drug of choice for analgesia in patients with liver disease. They are mostly metabolized in the liver. They are, however, reversible with naloxone. So if you happen to give a dose that's a little bit high, or you give a standard dose and your patient has an unexpectedly exaggerated reaction to that drug or response to that drug, you can reverse it with naloxone. There is some question that particularly the pure mu agonists like morphine, for example, may lead to constriction of the sphincter of Oddi near the pancreatic and common bile duct outlets, and that this may predispose patients to developing pancreatoduodenal reflux, and that might predispose our patients to getting pancreatitis. It does happen that the sphincter of Oddi does constrict. What is not so clear is, does every patient that gets morphine develop pancreatitis? And it seems that that is not the case. And so the clinical significance of this contraction of the sphincter of Oddi is really not, may not be as significant as we would think based on the physiological studies that have been done when we look at morphine and its action on the sphincter of Oddi. Remifentanil is, which I'll talk about in a second, has extrahepatic metabolism. Okay, I'll talk about that in a second. So this is a drug that is related to fentanyl. It's extremely short-acting, but it is not metabolized in the liver. So this is an opioid that perhaps we might preferentially select if we were able to get hold of it in order to give our patient very, very good analgesia. It's a pure mu agonist, okay, but it does not require on the liver to metabolize it, and so we find that our half-life is very seldom, if at all, prolonged over a non-liver disease patient. All opioids are MAC-sparing, which means we can use less inhalant anesthesia. Why is that important? Well, inhalant anesthetics like isoflurane, for example, are extremely depressant to the myocardium, so they decrease cardiac output. They're also markedly vasodilatory in their action as well, so we get significant decreases in systolic arterial blood pressure and significant decreases in cardiac output with inhalant anesthetic drugs. And in a patient that has perhaps severe liver disease, perhaps acute liver necrosis, in the case of our little patient, our little beagle that's eaten a cycad, he's got other problems that are going on. He has an elevated urea creatinine. We might not want, in fact, I would venture to say we definitely don't want necessarily to drop his blood pressure anymore and potentially cause some damage to his liver and his kidneys as a result of that. So max sparing is good. That's one of the reasons why we want to use opioids. We're going to use a continuous infusion. Normally I start off with a small bolus at the milligram per kilo or microgram per kilo dose that I'm going to choose, and then I put my patient on a continuous infusion to kind of avoid the peaks and troughs of both analgesia, but also to provide a more reliable max sparing effect. Given that a lot of opioids also depress ventilation, providing ventilation support is really, really helpful, particularly if you're monitoring patients' end-tidal CO2. The decision to ventilate is pretty obvious. You'll see your CO2 creeping up above 45 millimeters of mercury. But that's the time we're going to want to ventilate, because we don't want hypercapnia causing vasoconstriction in our liver. If you don't have a capnograph in your practice, or you're not able to monitor CO2, then just look at your patient's respiratory rate and their effort of breathing, and maybe ask a nurse or assistant to perhaps just augment that patient's respiration to the tune of around 10 mils per kilo of body weight when they're squeezing the anesthetic rebreathing bag each time that patient breathes, in order to provide some ventilation support to try to avoid hypoventilation after you've given opioids. You want to avoid thiobarbiturates. They've got extensive liver metabolism, prolonged duration of action. Oh, now we're talking about induction agents, sorry. For induction agents, thiobarbiturates are what we want to avoid: extensive liver metabolism, prolonged duration of action, and most importantly, they are arrhythmogenic unless you use them in conjunction with acepromazine. We've already ruled acepromazine out as a pre-med. We're not going to use it. That by default means we're not going to use thiobarbiturates, but also because they're extensively metabolized in the liver. We can use ketamine for anesthetic induction, but it does have pretty extensive liver metabolism. The reason we might want to use it is that it does provide a relatively stable liver blood flow, so we get reasonably good blood flow to the liver. It's not the best drug, though, that we could choose. It is associated after administration as a bolus with slightly reduced liver oxygen delivery, so typically as an induction agent, it's not what I'm going to reach for, mainly because lots of liver metabolism, a long half-life, and then slightly reduced liver oxygen delivery. What about alfaxolone? How many of you are using alfaxolone for these patients? A lot of us use alfaxolone in everyday practice. I think it's a great anesthetic drug. However, it is another drug that acts at the GABA receptor within the brain. In fact, it increases channel activity at the GABA subtype A receptor. So it increases, the increase in GABAergic compounds in a patient that has hepatic encephalopathy may increase sensitivity to alfaxolone. We do require some dose reduction because it is metabolized in the liver as well, and we may see some unexpectedly quite profound central nervous system responses to alfaxolone administration in these patients. So generally speaking, propofol is a much safer option than alfaxolone. So which brings us to what are we going to use, and propofol seems to be one of the best things we could use. It's rapid acting, it's got a short half-life, it has rapid distribution, it is metabolized in the liver, but it also has extrahepatic clearance that actually clears propofol from circulation at a much faster rate than the rate of hepatic metabolism suggests. So there is some thought that propofol is metabolized also or cleared from circulation outside of just the liver. So even if you have a patient with severe liver disease, your propofol will still be cleared by other means as well. Now, I have not got access to etomidate, but in reading and preparing for this lecture, many of you, particularly in North America, I think, do have access to etomidate. It's an imidazole. It has rapid distribution. Its metabolism is not significantly altered in liver disease because it's metabolized mostly by ester hydrolysis elsewhere in the body. It has much more rapid clearance than thiopentone. It's got good cardiovascular stability, but it does decrease liver blood flow. So that's kind of a negative against etomidate. And if you are going to use it for a long period of time with repeated injections, you can get hemolysis with the propylene glycol carrier there. So those are two of the drugs in which we may choose to use. And most of us in general practice would probably choose propofol for these patients, along with an opioid like fentanyl or remifentanil as our pre-medication to administer to these patients to get good induction. What about for maintenance? Well, maintenance with an inhalant only has got, most inhalant drugs like isoflurane, sevoflurane and so on have got minimal liver metabolism, but you do need to watch the blood pressure, and at higher doses they can hypoventilate as well. In fact, there was an interesting study looking at isoflurane and sevoflurane that induced severe liver insulin resistance in a canine model. So what they did was they inserted catheters with radioisotopes of glucose into these patients, and then anesthetized them with isoflurane and sevoflurane, and then they looked at insulin, at changing blood glucose concentrations and insulin concentrations as well, and they found that there was significant insulin resistance, which is actually going to bump your glucose level up, but it's also, which is actually going to bump your glucose level up, but what it can mean is that your hepatocytes and your other cells in your body may not be able to gain the glucose that they actually need to metabolize properly, so you can end up with some cell dysfunction as a result of that. So what most people would suggest is that we give our patient not just inhalant drugs like isoflurane, but that we have some sort of continuous infusion with an injectable, be that fentanyl or remifentanil or maybe even propofol, so that we get less hypotension and we reduce our reliance on that inhalant, so we get less vasodilatation and less negative inotropism from our inhalant. I've seen someone's written there lidocaine and ketamine. Just watch the lidocaine and the ketamine. Yes, certainly in a very painful patient I would use lidocaine and ketamine, but we will need to watch the doses of the lidocaine and ketamine because they're both going to be significantly prolonged when in the patient with liver disease. So that's the only thing I'll probably say about that. Can we use methadone as a pre-med? Yes, you can use methadone. We're probably going to use less methadone than you would use in most critically unwell patients. So if your standard dose for, let's say, a dog with a GDV might be 0.1 to 0.2 milligrams per kilo, you may want to start off with perhaps half of that dose to begin with and see what central nervous system and respiratory depressant effects that you see, and then perhaps adjust the dose upwards if you need to. With ketamine, a standard dose for analgesia is anywhere between 0.3 and 0.6 milligrams per kilo per hour, and maybe 0.3 to 0.6 milligrams per kilo as an IV bolus for analgesic effect. If you are going to use ketamine as an adjunct analgesic, you may want to drop that dose down to maybe, 0.15 to 0.2 milligrams per kilo per hour and titrate it up. It's better to start low and to increase the dose than it is to start high and be left with a very, very severely obtunded patient going forward. Interesting question. Can we use propofol and diazepam together for induction, or is the diazepam not needed? You know what? That's a great question. I think probably what I would do, if I was going to combine an anesthetic drug, I would give one drug, in this instance probably the propofol to begin with, and then if I needed something extra, maybe you could reach for something like fentanyl, or you could use diazepam if you really wanted to. Again, just bear in mind that the sedation you'll get with diazepam can be really profound if you have a liver patient that's got hepatic encephalopathy as well. Can we keep the patient entirely on propofol? Yes, you can keep them entirely on propofol. That's perfectly okay to do that in these patients. Let me see. I'm just scanning through a couple of the questions there. You guys are asking some great questions. If albumin is low, would you still use propofol that binds to the protein? I'm going to talk about protein binding of drugs because this is a really interesting thing. You know how I said we should probably drop the doses? The standard induction dose for propofol is around sort of 6 milligrams per kilo. We use about half to two-thirds of that as our induction dose, and then we give it to effect. So in some patients we might be drawing up about 4 milligrams per kilo as an induction dose, and we might only use 1.5 or 2 milligrams per kilo to induce the patient if that's all it takes for us to be able to safely intubate the patient. Now, propofol as a continuous infusion as a maintenance agent is a really good question here, isn't it? Very hypotensive. Propofol's biggest drawback with hypotension is during bolus induction therapy. As a continuous infusion, it can decrease your blood pressure, but usually the effect is much less noticeable than it is after an IV bolus. So we maintain a lot of our ventilator patients on propofol continuous infusions, and their blood pressure is usually maintained reasonably well with doses of propofol that we're perhaps topping up with other drugs like fentanyl or butorphanol or so on. So I think if you're using a combined approach, you can perhaps get a happy medium of continuous infusion of a drug like propofol and maybe supplemented with another drug like fentanyl or remifentanil in the liver case, for example, so that you decrease your reliance on the propofol. Your BP is probably going to be a little bit more stable, and then you can use just enough isoflurane to keep these guys asleep if you absolutely need to. What about butorphanol as a pre-med? Yes, you can use butorphanol as a pre-med. Butorphanol is actually really, really nice in these patients. It's not associated with a great degree of sedation in these patients either. But one of the drawbacks is obviously it's not a very strong analgesic agent. So frequently if you're doing something that's a surgical intervention, you might want something a little bit stronger than butorphanol. Let me see. I'll get to, remind me, Helen, to talk about protocols for CRIs for surgery, and I will do that at the end. Cool. All right, I could have paused there for questions, but I've answered them all. This lecture has been brought to you, it's a bit of advertising, by the Vet Education course Hepatobiliary Emergencies in Small Animal Practice. It starts on April 20th. We're going to talk lots and lots about liver disease and decode a lot more things about the liver during the course. But let's jump into pre-anaesthetic management. Now that we've talked about drugs, kind of got an idea of what we want to use, let's talk about our pre-anaesthetic management, because if you recall, our patient wasn't looking all that crash hot when we were thinking about giving him an anesthetic. So we have to manage some of his problems before we even consider anesthetizing him. Otherwise, we'll anesthetize him and his anesthetic outlook is going to be a lot worse. So I like to look at critical patients when they're going to be anesthetized as like having a checklist of everything that's wrong with your patient and trying to fix as many things as possible before you give your anesthetic drug, because all anesthetic drugs are toxic to our patients. And unless we fix up our patient as much as possible, they have a much higher chance of having an adverse reaction to these toxic compounds we're going to give them in the form of an anesthetic. So the sorts of things we're going to look after are hepatic encephalopathy, coagulopathy, glucose concentrations, albumin, low blood pressure, ascites, reduced drug metabolism, and electrolyte abnormalities. We've seen this list before. So let's talk about hepatic metabolism. We have to be careful about our drug selection, and hopefully we've shed a little bit of light on some of the drugs that we can use. Reduce the dose rates. Unfortunately, there's no simple formula that we can use in order to reduce the dose rates. And when patients have liver dysfunction, there are very, very complicated formula that can give you an idea as to how much you might need to reduce the drug dose. But each patient is different because each patient's cardiovascular system is different, their inflammatory response is different, their underlying disease might be different as well. So we might reduce our drug dose rates by X amount because we have spent 1.5 days doing the maths that's associated with trying to get that done, right? I'm being facetious there. But the formula are not all that easy, to my eyes at least, and in general practice, oftentimes we don't have the time to consult a mathematician to help us do these calculations. So we reduce the dose rates by a certain amount, and practicality might suggest that we reduce them by maybe a half, maybe 2/3, maybe 3/4. Depending on the patient's comorbidities, electrolyte disorders, and so on. And we give a little bit, and then we give a little bit more if we need to, and then we give a little bit more. The worst thing we could do is to calculate a dose and say, okay, I'm going to give my patient half of that dose, and to give all that half all at once. And I don't think there's many of us that would do that. But if we did, a fair number of our patients could end up dying during anesthetic induction periods, because some patients will be extremely sensitive to anesthetic doses that are a small fraction of what we would normally give them. We need to remember ventilation therapy and blood pressure support as well, so that we support our liver circulation. In terms of hypoglycemia, monitor your patient's glucose on presentation or just before surgery and every 30 to 60 minutes. You need to have prepared a solution of 2.5% to 5% glucose as a continuous infusion in patients, particularly if their glucose is hovering at the lower end of normal. Just remember the glucose, to measure your glucose if anesthetic recovery is prolonged, or if you have an unexplained increase in depth of anesthesia when nothing else has changed. Check the glucose concentration in your patients. In terms of albumin concentrations, as albumin concentrations fall, we get an increase in drug-free fraction. There was a question there before about do we want to give drugs that are highly protein-bound, because if the patient's hypoalbuminemic, we get an increase in free drug within circulation, and so that free drug is actually more physiologically active, or there's more of it there that can exert its effects on the central nervous system as an anesthetic. So hyperalbuminemia almost universally increases free drug fraction. Take this for an example. Let's say a non-steroidal anti-inflammatory drug, most of which have got 99% bound to albumin, so only 1% of that drug is free. If our albumin concentration decreases, okay, by let's say 1%, we can nearly double the amount of drug-free non-steroidal anti-inflammatory drug that is available in circulation. If we have a patient who has less albumin than it would normally have, we are going to dramatically increase the free concentration of a highly protein-bound drug. Now, most opioids have anywhere between about 80 and 95% protein binding. I think a couple around in the 70s there. Fentanyl's got quite high protein binding, so if we get a decrease in albumin concentration, we need less fentanyl to achieve the same clinical effect. And the same goes for a large number of our anesthetic drugs. The other thing that we have with hyperalbuminemia is reduced colloid oncotic pressure, and that reduces blood volume because more fluid can leak out of blood vessels into the interstitium, and that actually increases the volume of distribution. So some of our drug that we give is going to end up in acidic fluid. It's not particularly useful. It may be reabsorbed into circulation, but it will end up back in there to begin with. So some of the hyperalbuminemia effects that increase free drug fraction, if we have patients with peripheral edema or ascites, for example, some of those effects are mitigated by the massive increase of volume of distribution. What are we going to do to manage hyperalbuminemia? Well, the best thing we can do is we can transfuse our patients with fresh frozen plasma at a dose of anywhere between 10 to 30 mils per kilo in the immediate 4 to 6 hours prior to us anesthetizing our patients. It's very, very difficult to increase the albumin concentration with using fresh frozen plasma, but what we're going to try to do is to minimize the further decrease in albumin concentration, and we're going to provide albumin for the duration of our patient's anesthetic. Human serum albumin, concentrated serum albumin has been used, as has canine concentrated serum albumin. There is not a lot of information in this particular subset of patients on the effect that those transfusions have on drug binding, but if they do increase the albumin concentration, one can expect more drug to be bound, and our patient is more likely to have a slightly less abnormal clinical effect to administration of an anesthetic drug. What TP level would we consider for a plasma transfusion? Thanks, Steph. That's a brilliant question. Look, normal serum albumin concentrations, around about, the low end of normal is around 23 grams per litre. I think if you're heading less than sort of 19 or 20 grams per litre, that's when I would start. I think generally speaking, the earlier you give your plasma transfusion, the better the effect is going to be, particularly if you're going to subject your patient to an anesthetic. But I think that's a great question. What tests are, actually we'll talk about coagulation in a second. Hypotension is a real problem in these patients. The causes are, hypovolemia from vomiting and diarrhea, but also hypoalbuminemia leading to fluid loss into third spaces like the abdominal cavity and the thoracic cavity. And many of these patients can be hypothermic, and they can suffer from quite significant vasodilatation as well. So we treat these patients with fluid therapy, preferably a lactate-free fluid therapy. So Ringer's acetate is probably better than a lactated Ringer's solution for these patients. We treat shock, we rehydrate our patients with this fluid, and then we provide fluid for maintenance. It's important not to fluid overload these patients because we're going to be using predominantly crystalloids like Ringer's acetate in these patients, and if we and 3/4 of the fluid that we give to our patient is going to end up in our patient's interstitium. So we don't want to fluid overload them, but we do need to treat them for shock, so get our heart rate, pulse quality, blood pressure back into the normal range if we can with fluid therapy, and then we rehydrate our patients, then we drop our fluid rates to maintenance rates. Now, if our patients don't respond to fluid therapy, if we're treating them for shock and they still maintain that they've still got hypovolemia, or if we have evidence of poor tissue perfusion, such as an increased urea and creatinine, the drug I'm going to reach for first is a positive inotrope, the dobutamine, and I'm going to start off using that at around 5 micrograms per kilo per minute. And the reason I'm going to do that is that will increase cardiac output, so that we should get an improvement in tissue perfusion because of the improved contractility in the heart as well. Then we'd start to add in vasopressors. Now, many of you will have been using dopamine as a vasopressor. Noradrenaline is thought to be a superior vasopressor. It has many effects that I don't have time to go through in this lecture that would render it better than dopamine. And failing that, we could use vasopressin as well. Vasopressin itself does not have any direct effects on the heart, but it is a very, very good peripheral vasoconstrictor. Coagulation abnormality. Someone's mentioned, do we want to, what coagulation tests are we going to be using? We want to check the activated clotting time. If that's all you have, that's perfectly fine. If you've got a machine that measures PT and APTT, then use that. Always do a blood smear and do a manual platelet count and check that off against your machine reading as well. Typically, low platelet concentrations in combination with prolonged clotting times or secondary clotting times like your ACT, PT and APTT typically suggest your patient may have DIC. We're going to treat these patients with fresh frozen plasma, and we can start them on vitamin K1 if we haven't already, usually about 12 hours before a planned anesthetic. Now, someone else mentioned, is there any benefit in using sort of anti-plasminogen medications, things like tranexamic acid? And the short answer to that is that yes, they can be. If you can't normalize the clotting time prior to surgery, then using tranexamic acid can be helpful. And the dose of tranexamic acid that I normally use is about 10 milligrams per kilo. You give it slowly over about 20 minutes or so, and then you can put your patient on a continuous infusion of 10 milligrams milligrams per kilo, running it over about every 3 or 4 hours after that first dose has been given, and repeat that every 6 hours or so. Hepatic encephalopathy. We're going to talk a lot about this in the course that we have coming up, but typically the symptoms are altered mentations. You're just an animal that's not quite right, severely obtunded, depressed. They may be seizuring, they may have altered gait, they may vocalize, they have got a whole range of responses. They may have central nervous system depression. They've got heightened sensitivity to sedatives like benzodiazepines and any drug with an increased half-life as well. We can add in there alfaxolone as well, because alfaxolone we know is going to act on the GABA receptor. So what we need to do for our patients is adjust the doses of our drugs, typically much lower. Our patients already dull and depressed, so we may not need to make them much more dull and depressed to anesthetize these patients, and we need to manage their underlying hepatic encephalopathy. And we do that using drugs like metronidazole and lactulose, for example, to decrease the amount of ammonia that's absorbed from circulation, from the intestine into portal circulation. And, those things are thoroughly recommended to manage well before you give your patient an anesthetic. How quickly does vitamin K1 improve coagulability? It does have to have, it doesn't require metabolism by the liver to activate it. So the liver does have to metabolize vitamin K1 in order to make, or it uses vitamin K1 rather to make clotting factors. Okay, so we have our vitamin K dependent clotting factors 2, 7, 9, and 10 that require vitamin K as a cofactor for production. So if our liver is unable to manufacture clotting factors because of a loss of function, giving vitamin K1 may not be of much benefit. But in a patient that has perhaps an acute hepatopathy, acute liver necrosis, or like the patient we're talking about with psychad toxicity, if this patient still has sufficient reserve liver capacity, we may be able to exert a small effect on coagulation by providing an active form of vitamin K in the form of vitamin K1 that doesn't require recirculation by vitamin K epoxide reductase enzyme in the liver, which may have reduced activity, if that makes sense. Good question. Can we use synthetic colloids instead of fresh frozen plasma? That is a huge topic, and it's a great question, and I'm so glad that you asked that question, because it's important. In patients, most of you will have heard by now that synthetic colloids are relatively contraindicated in patients with sepsis or septic shock, because they may increase the likelihood of your patient developing acute kidney dysfunction. Okay, or acute kidney failure. And that's certainly been found in humans. It's suggested in the veterinary literature as well, although our studies were quite a bit smaller. So should we use these in patients that have got significant liver disease? Well, in my opinion, it probably depends a little bit on the liver disease. If you've got inflammatory liver disease, such as acute liver failure or acute liver necrosis, or you've got a condition like psychad toxicity in which there is significant liver cell destruction and probably associated inflammation going on there, then I would probably err to steering away from the use of synthetic colloids instead of using fresh frozen plasma in these patients, mainly because I don't want to place my patient at any increased risk of developing organ dysfunction like kidney failure, and the fact that inflammatory conditions of the liver are more likely to lead to an increase in vascular permeability. So my colloids are more likely to leak out of my blood vessels into the interstitial spaces, which is where they're going to cause problems. However, in chronic liver disease, perhaps you've got a cirrhotic sort of liver or something like that, then in those patients that don't have serious inflammation in their liver, you possibly could use synthetic colloids. The downside is that most of them, even including the heterstarches, will cause a little bit of a prolongation in clotting times. You do have to make sure that you check your clotting times. You keep a really close watch on those. So that's kind of like a very abbreviated answer, but hopefully that sheds a tiny bit of light on that question. I love that question. I'm going to knock off a couple of these questions here. I think I've answered the pre-anesthetic coag profiles there, so you can use pretty much whatever coag profile you have in your practice there as well. And we've talked about the use of coagulation agents also. And I think we'll move on to the last part of the lecture, suggested protocols. Let me guess. So I mentioned I was going to talk about remifentanil. I've kept remifentanil as a mysterious anesthetic agent that I've now just brought out. I've told you a tiny bit about it. It's a propionic acid methyl ester link, okay, by metabolism. It's susceptible to metabolism and blood esterases, susceptible to metabolism by tissue and blood esterases, so it doesn't require liver metabolism. Remifentanil has the addition of this little propionic acid methyl ester link attached to the fentanyl molecule, and that can be esterified really, really easily by pretty much any tissue in the body, including blood. So there's very minimal liver metabolism. Its duration of effect is therefore unaffected by either renal or liver function. The metabolites of this drug, once they're esterified, are about 4,600 times less potent than remifentanil, so they're not very active. It's got a short duration of action, okay, about 10 minutes or so after a bolus. It's non-cumulative, so these guys wake up really quickly. You can give a bolus followed by a CRI, and the doses are roughly the same as what you'd use for fentanyl. You can combine remifentanil and isoflurane and isoflurane for a really nice stable anesthetic. The remifentanil will decrease the MAC of isoflurane, so you might be able to run your patients on maybe 0.8 or 1% isoflurane instead of 1.5% isoflurane, and these patients will have a much more stable blood pressure. It's non-cumulative. To my way of thinking, this is isoflurane and remifentanil CRI for maintenance would be an ideal anesthetic protocol. Now, not everyone has remifentanil. You could substitute that for fentanyl, but you're going to need to be a little more careful with the doses, and I'm going to show you what doses we would use. So this protocol using remifentanil and isoflurane has been demonstrated in this study here, looking at 5 dogs with liver disease undergoing liver biopsy, and they found that they had really nice anesthesia. One of the things they did notice was that they sometimes did need to turn the isoflurane concentration up to sort of 1.5–2%, and subsequently the blood pressure did fall in those patients. So you may need to just run your remifentanil concentration at a little higher than they did in this study, and this is the dose that I would probably recommend, anywhere between 2 and 8 micrograms per kilo per hour. Just watch the ventilation as you approach this 8 micrograms per kilo per hour. Sometimes the ventilation can decrease a little bit. As far as other protocols that might be suggested, we've already got fentanyl perhaps as a pre-med, 2 to 4 micrograms per kilo IV, and we give propofol as an induction agent. Then we can maintain our patient on fentanyl and propofol CRIs, and we have isoflurane just enough to effect. I've used this myself in some patients with acute liver disease to place feeding tubes, and it gives really nice anesthesia, fairly stable in terms of blood pressure and so on. The trick is to keep the isoflurane as low as you can, even though it's not metabolized in the liver that much. Propofol and fentanyl combined as an anesthetic combination are really, really helpful. Note that I'm using 2/3 of the calculated induction dose of what I would normally do. That's what I'm going to draw up in a syringe. Normal dose is 6 milligrams per kilo per propofol. I'm going to draw up 4. I might only use 1.5 or 2 milligrams per kilo. I'm just going to take my induction really slow over about 2 or 3 minutes or so in order to try to get to the stage where you're happy to intubate your patient. We mentioned butorphanol before, and we certainly can use that. We can then induce with propofol, and you can maintain your patient on butorphanol CRI plus propofol and isoflurane to effect as well. This is what I would do for a relatively minor procedure, butorphanol not being a terribly good analgesic. You could use fentanyl and ketamine if you wanted to, if you had a very painful thing to do, if your patient was painful as part of their pre-existing illness. And you can induce them with propofol, maintain them on fentanyl, ketamine, and isoflurane to effect. Someone's just asked about, what about lidocaine? Can we use lidocaine as a CRI to reduce the inhalants? Yes, you can. Lidocaine is, again, pretty highly protein bound, so you need to drop the dose. It can be in patients with hepatic encephalopathy, you may get quite profound sedation as a result of using it. So again, I'd probably be using a dose that was maybe 25 to 50% of what I would be using in a normal healthy patient or a patient that did not have liver disease. But I think that's great. Good question. How is remifentanil eliminated? It is eliminated, or its metabolites are eliminated in the urine, so it doesn't even require biliary excretion for that either. So let's go back to our patient. We gave this patient fluid therapy. We gave him 15 mils per kilo of fresh frozen plasma to normalize his clotting time. We've got a 10% glucose solution ready in case he became hypoglycemic. We've got his dobutamine and noradrenaline ready, and we warmed him up prior to anesthesia. A lot of these patients will become profoundly hypothermic when we anesthetize them, and please type in if you've seen this in really severely unwell liver disease patients. So active warming begins prior to anesthesia, and we would recommend that you start putting, if you've got a bear hugger, to put that in the cage with the patient before anesthesia for maybe 15-20 minutes or so that you warm up the patient. Now, some people argue that that's going to cause vasodilatation in the patient. Well, yes and no, but dogs lose their heat predominantly through panting rather than directly through their skin. What we're trying to do is to try to warm up the outer layers of the onion of our dog. Okay, if you view it, let me clarify that. If you view the heat loss in a dog, dogs are very much like an onion when it comes to heat. So the central part of the dog is usually about 2 degrees Celsius warmer than the periphery of the dog. So what we're trying to do is we're trying to decrease the gradient of heat loss from our patient from central circulation to peripheral circulation by heating up the outside of the dog. When it comes to when we anesthetize our patient, we haven't got the gradient of 2 to 5 degrees Celsius or even 10 degrees depending on how cold the room is that you are working in. For that patient to lose heat. Yes, they're going to lose heat from their periphery, but if we warm that patient up beforehand, we stand a better chance of maintaining core body temperature. Heating pads, really be careful with heating pads because they can cause thermal burns. I'm not a huge fan of those. Water recirculating blankets, yes. Thermal blankets, yes. Bear huggers, yes. Heating pads are can be a real challenge. I've seen some awful burns in patients that have urinated, or the surgeons have sloshed fluid around with their surgery, and the patient's got wet, and that wet skin has contacted the heating pad, and they've got awful burn injuries. So do take care if you are using heating pads as well. A couple of questions, really good questions here. What fluid rate do we use in the perioperative period? So in the immediate period before surgery, okay, we will make sure that we've treated shock and rehydrated our patient. We've got them on maintenance just before surgery. We'll probably turn them up to perhaps twice maintenance rate, so maybe 5 mils per kilo per hour in the dog, maybe 4 or 5 mils per kilo per hour in the dog. Nothing like the 10 mils per kilo per hour that used to be recommended a long time ago. So much more conservative fluid rates during the intraoperative period. If my patient becomes hypotensive, if I've ruled out my inhalant anesthetic and blood loss and other things as a reason for that, then I'll give my patients shock rates of fluid in order to try and help manage that. But there's no evidence to suggest that running your patient on 10 mils per kilo per hour of isotonic crystalloid prevents them from becoming hypotensive due to any particular cause. What it does do is it dramatically increases the amount of interstitial fluid that these patients accumulate while they're having this high rate of fluid under anesthesia. So hopefully that makes sense. Can you use dextrose instead of glucose? Yes, you can. Dextrose is just the isomer of glucose reflected, so it's like a mirror image of glucose. It can be used instead of glucose. It's metabolized in exactly the same way. Now, how long do we have to wait from pre-med until we give the induction? That's another good question, Rishi. So Depends what pre-med you're giving. If I'm giving a patient a pre-med like fentanyl, for example, or remifentanil, you can have that patient sitting on the anesthesia prep table. You can give your drug and wait for 4 or 5 minutes and then give your induction agent right then and there. And that's what I use for fentanyl. I'll probably wait for 5 or 10 minutes beforehand because I'm going to give my pre-med intravenously rather than sub-Q or IM. And that's a good question. I think most of the pre-meds that we're talking about giving would be given intravenously to a patient rather than subcutaneously or intramuscularly, mainly because we've got more of a guaranteed access of that drug to the circulation. It's going to get where we need it to in the period of time that we expect as well. But that's a great question. All right. So for this guy, we gave him a pre-medication of fentanyl, 2 micrograms per kilo, then we had him on 2 micrograms per kilo per hour. This is the lower end of the normal dose for fentanyl as a pre-med and analgesic. For propofol, 4 milligrams per kilo IV to effect, and then an increase to CRI of fentanyl to 4 micrograms per kilo per hour, and we just maintained him on isoflurane and fentanyl for his feeding tube placement, and he did pretty well with that. I do want you to just have a look. I will forward this article to you. It's the effective blood protein concentrations on drug dosing regimes. A really nice practical guide for any of you who like to mess about with sums and things. Just be aware that if you do your calculations and you get a dose reduction recommendation using the formula in this article, that you look at your patient as well. You might need to reduce the drug dose a lot more than what your calculations suggest, or you might need to give more drug than your calculations suggest. It's very fluid because our patient's physical status and physiological status is very fluid as well. That's just a few of the references that I have used for this evening's presentation as well, but I do want to thank you all for coming along this evening, and I'm super happy for you to ask me any questions at all about the course, about the lecture as well. Now, a dosing protocol for a CRI for, I think that was for propofol, I think. We had a question for that. So dosing protocol really, as I mentioned, probably 2 to 4 milligrams per kilo as an induction dose, and usually what I'm doing to maintain my patients for a CRI is actually use that induction dose as a starting point for my continuous infusion rate. CRI dose rates for propofol vary between 6 and 11 milligrams per kilo per hour, depending on what your patient has as other drugs on board. So if I'm using, if I manage to induce my patient with 2 milligrams per kilo of propofol, then that's probably the CRI dose rate that I'm going to start with, 2 milligrams per kilo per hour for that patient. So I think that's a great question, and I think that you're going to adjust that up and down depending on your patient's response to the medication that you're giving as well. The same goes for, if you have perhaps a patient who you're also running on fentanyl, for example, you may need to decrease the dose of that CRI as well. Lovely. Alpina has just put up the certificate for this lecture. Thank you very, very much again for coming along this evening. Don't forget, we do have this course, Hepatobiliary Emergencies in Small Animal Practice. It starts on April 20. If you have any questions about the course at all, please feel free to shoot us through an email, but check out the full course content at veteducation.com.au. Stay safe, everybody. I know we live in very, very interesting and somewhat terrifying times with COVID-19/coronavirus around the planet. I wish you and your families all the very, very best. I hope that you manage to keep safe and healthy during the next few months as this thing circulates around the world, and we hope to see you all again very, very soon. Thank you and good evening.